Perfect. Well, first of all, thank you for this invitation. It's a real pleasure. It's very humbling to be here to talk to you guys. And I'm glad I met the residents yesterday. So my topic is going to be what is quality of life and does it matter? And lessons that I learned from working with children and adults with spina bifida. I try to make it relevant to people who don't necessarily work with kids as well. So hopefully not everybody falls asleep. There's some objectives, but I wanted to start off with a small story, okay? And I'm thinking of the spring of 2011, and I'm applying to my Pediatric Urology Fellowship, and I'm sitting across the desk from Mark Kane and explaining to him why I want to go to Indiana and why I want to do pediatric urology. And I told him I wanted to be an excellent reconstructive surgeon, and I also told him I wanted to do research that would help us find out if we're actually helping kids when we treat their incontinence. And I wanted to know, through my work, what treatments might benefit a particular kid more. Because we didn't know, and by and large, we still don't know the answers to those questions. And he sat across the desk and kind of paused for a second and said, Konrad, that's been on a lot of people's minds for a long time. And if we're gonna do this, let's do it here in Indiana. We can make it happen. And so I wanted to go to Indiana to make sure that I could work with the largest spina bifida population in the world and with the support of people who would help me do this. And I wanted to bring some experience I had when working with quality of life in prostate cancer to pediatric urology to answer some of those unanswered questions. So lesson one, what is quality of life? Everyone here has heard this term, but very few people actually understand it. So the World Health Organization defines quality of life as individuals' perceptions of their position in life in the context of the culture and value systems in which they live in relation to their goals, expectations, standards, and concerns. And that's a whole lot of words. But if you kind of focus on what it really signifies, their individual perceptions. This is a concept based on your own individual experience. It's not a task-based thing. It's what is your experience of your life at the particular moment. And it happens in the context of what you're doing, what you're living, your culture, your value systems, along with all sorts of other things that are going on in your life, your goals, what you expect to achieve. And so it's really an experience and your perception. And this is another definition that I like to think about from one of our patients that participated in one of our studies. It is a 20-year-old man with spina bifida. He said, I have a very good quality of life. I'm always fighting for what I want. All my goals, all my dreams. I'm pretty sure I'm able to have a total normal life. So what is health-related quality of life? It's a part of quality of life, and it's really the effect of health on your ability to have a fulfilling life. And it may be condition-specific. Maybe it's related to prostate cancer, bladder cancer, spina bifida, skiing accident. The nuance is not captured by general instruments. Just look at quality of life overall. So what is spina bifida specific health-related quality of life? Well, if you look at the big picture, quality of life, within that you have health-related quality of life, and within that you have spina bifida specific health-related quality of life. And because it's a lot of words, I'm going to call that small box quality of life. It's just easier to say. So what quality of life is not? Because a lot of people misuse that term. It's not the level of function or ability. It's not whether or not you can walk up and down the stairs. It's not if you're continent, because that's not a perception. Those are tasks or things that you do. It's not a symptom score. So the AUASI is not a quality of life measure. It's a symptom index. Satisfaction with surgery is different. Decisional regret is also different. They're related, but they're distinct ideas. So why should we measure quality of life in spina bifida? Well, one of the main goals of managing patients with spina bifida is not to cure them, but to improve their quality of life. But if we can't measure our outcome, can we really assess our success? It also allows for a needs and intervention assessment, and it's been shown in the general population that quality of life serves as a better predictor of both mortality and morbidity than some of the objective measures, like blood pressure, for example. So how do we measure quality of life? We use questionnaires or instruments, and we basically use a ruler. And you need a ruler to measure anything reliably. So what do you need? What are the qualities of a good quality of life ruler? You need standard answers. They need to be validated. And I'm going to argue that it needs to be condition specific, not generic, patient administered and not proxy administered. And also it should be focused on the clinical value, clinical meaning rather than on research. Why should it be condition specific? I think this cartoon illustrates that well. You're applying a standardized test to everybody, a bunch of animals, and the tester says, for a fair selection, everybody has to take the same exam. Please climb that tree. You don't have to be an expert to know that some of these guys will be disadvantaged. And so generic instruments, and you probably saw them in papers or you've used them, the HRQOL, the SF36, SF12, they all assume normal functioning. Normal is that you're able to run, climb stairs, etc. So it assumes a normal that might not apply to some people. Aside from the fact that I just told you that the questions based on function are not quality of life. So there's an inherent error here in these instruments. In addition, they don't capture items that are important to people with spina bifida. They don't ask about continence, they don't ask about pain. They talk about other things. There are many studies that show that people with spina bifida have lower quality of life than people without it. Here's an example. They use the HRQOL, generic instrument. And you don't need statistics to notice that the spina bifida sample has lower scores than those with congenital hydrocephalus, and even lower than the controls, the non-clinical sample. But guess what? They used a HRQOL questionnaire, which means that this may not be real, this difference, because some instruments are inherently biased against spina bifida or against disability. A low score is not given because you're doing poorly, but because you have spina bifida. And so a good ruler measures things that are relevant and important to people with spina bifida. Why should a questionnaire be patient reported? And it's true that management affects patients and families, but the best way to assess patient-centered outcomes is to ask the patient. And it's also been shown in previous studies that parents, caregivers, and healthcare providers tend to underestimate the quality of life of people under their care. And that's known as the disability paradox, where people with disabilities actually have a higher quality of life than someone without a disability would think. And so remember that young man I mentioned, the 20-year-old who had an excellent quality of life? And maybe when you heard that quote, you weren't exactly imagining a 20-year-old in a wheelchair with hydrocephalus who had a part-time job at McDonald's. But that's who he was. His perception of his life might have been very different than to someone sitting on the sideline and looking at it. And that's disability paradox. So how does that apply to spina bifida? We asked 250 teens and 532 adults with spina bifida to describe their quality of life, a single question. 89% of the teens and 77% of the adults said their quality of life was good to very good, something that might not be appreciated by someone who doesn't have that experience. And so in other words, you cannot really put yourself in the shoes of someone with a disability. And that raises the question of how relevant it is to compare quality of life between people with and without spina bifida, or controls. Because both of those populations live with different challenges, and it's a bit like comparing apples and oranges. The other thing is that the questionnaire, any questionnaire that you're going to be using clinically, should be clinically useful. The primary goal should be to deliver better care and not to do research. That should be a secondary goal. And so it should be short and age appropriate. A kid should be able to understand it. It should be clinically relevant, and it really should be like an adjunct to everything else you're doing, the H&P, the imaging, the blood tests. And it should be in your hand with the answers before you go in there, so you can just talk about it. It can help your discussion. There are some published instruments out there that have been used as these rulers for quality of life. Here they are: the Nanigan instrument, the Kulkarni instrument, and the Parkin instrument, which is the only one with a child version. I went through these really fast, but you can see that they tend to be pretty long. The question is also, are they relevant? They ask questions about problems with tying shoelaces and being able to use the phone. I don't know if that's really clinically relevant or important to people with spina bifida. There was only the one questionnaire that actually had the questions for the kid, not the parent. And aside from one of them, there were really no questions about bladder and bowel care or continence. And so looking at these aspects of a good quality of life instrument that should have standard answers, that are validated, spina bifida specific, patient reported, and clinically useful, when I started there was no such instrument. And it's not for lack of trying. I just showed you 3 papers where people worked really hard to get something done that would be useful. Many people have tried. This takes effort, time, a lot of resources, and a lot of patient and family involvement. So what happens when you don't have the right ruler? And so this is a study that happens to be done here. And I want to applaud the authors because this is a really big effort and was a big contribution. A prospective study of 31 patients who are undergoing catheterizable channel surgery using the Parkin instrument, the last one in the list of 3 that I showed you, which at the time was the best we had. And guess what? There's no difference in quality of life after doing continence surgery. But is this true? Does the ruler measure what you think it measures? And can you really assess the impact of continence without asking about it? I think that's at least a big question mark, if not a flat out no. So, the second point, if something seems weird, and that study has a very weird finding that doesn't match your clinical experience. If something seems weird, you question your assumptions. So what's the problem? I don't think we had a good ruler, a good way of measuring quality of life. And so we don't have a good way of measuring the outcome. And that's because we have incorrect assumptions about incontinence with spina bifida. Because even subconsciously, as a model, we use incontinence in men after radical prostatectomy or stress urinary incontinence in elderly women. So what are these assumptions? These incorrect assumptions. We treat normal being dry, but a lot of people, if not all of them, have no baseline of continence when it comes to spina bifida. We also presume that success means going back to normal. But should everybody be dry when they have spina bifida? Some patients just don't care. We also think about it as a one event, not a developmental thing. You have surgery, develop incontinence. And here, people with spina bifida have grown up with incontinence, and the impact of it changes over their life. The other thing is, for the people that are used as kind of the starting point, urinary incontinence is very often one of the few problems they're struggling with. But in spina bifida, you also have issues with bowels, renal issues, chronic kidney disease, neurological problems, shunt malfunctions, issues with mobility, social problems. There's a whole lot of other problems going on, not just urinary incontinence. And so, how do we develop a good questionnaire? We have to ask what is important to people with spina bifida. So you ask the people, you ask the families, and you talk to the people in the know, the experts. So that's how we developed the QUALIS questionnaire. My goal was to develop something that was clinically useful, self-reported, and disease-specific. We interviewed patients, families, and experts in the field, and we started off with a library of 150 items. We engaged people in clinic, patients online, and we did some fancy statistics that I won't bore you, impress you with. It took 3 years. This was a long-term effort. As a result, we had 3 age-specific questionnaires that got validated. We had 415 adult participants from the States and over 100 internationally. These are some of the domains of the questions that we were piloting. So looking at the domains, independence was a big domain that kids and teenagers endorsed. Not surprisingly, health and relationships and esteem and sexuality were questions that pertained more to adults. And every single age group wanted to be asked and talk about bowel and bladder dysfunction. These are short questionnaires. 10 to 15 questions, takes 5 minutes to fill out. These are some sample questions that are included. And so I want to take a pause and think, and as I was preparing this talk, I thought about what is the thing that I learned from this? And this idea of how do you succeed in a research project that is impossible to do? Now, some things are impossible to do, and the advice would be stop doing it, move on to something else. But if something's just kind of impossible, and maybe there's a way around it, I think I can think of passion. No one cares about this project as much as you do. You're the champion of it, so keep going. But don't do it alone. Reach out to the people out there who are better at the aspect of what you need and to help you out. Engage them. Think differently. Don't do the same thing that everyone else has been doing. Use a different technology. Most of the participants in our study we reached out to online. A lot of this community lives online. And so that's what we did. We used SurveyMonkey, a free platform, to do that. Think long term, not just because the study will lead to other studies, there's going to be more questions that it raises, but also because this will take way longer than you think. It's going to take forever. Just keep going. So we have a questionnaire. What can it measure? So until a few years ago, we really had no idea if people with spina bifida really cared about incontinence or wearing protective undergarments. Which is kind of weird, but like we didn't know. So does incontinence affect quality of life in people with spina bifida? That's a very, very basic question. We treat it all the time, but does it matter? And the answer should be obvious, but it's never been demonstrated. So how many people who have spina bifida actually experience urinary incontinence? What about fecal incontinence? What's the big picture here, and does it matter? So when we looked at the adults, over half of them lived with fecal incontinence. 47% had both, and only 15% were content of stool and urine. These were very stark numbers. And so 3/4 live with urinary incontinence, half live with fecal incontinence. Does it matter? Do adults with spina bifida who are dry have better quality of life? Well, when you look at their quality of life scores, right over here, they're higher than those who are wet. This pointer is really slowing down. Do adults, so yes, it does matter. Does a dry interval of 4 hours affect quality of life? We use that interval all the time in discussions and clinical visits and papers. I'm going to use this. And no, it actually doesn't matter. So what kind of incontinence does matter? So you see a dose response here. With decreasing quality of life, the more someone leaks. So what's important is the amount, a little, medium, or a lot. We have not asked that before. What about fecal incontinence? Do those without fecal incontinence have higher quality of life? And this graph is flipped over, so the axes are a little different. And so 0 is baseline, negative scores means lower quality of life. Well, those without fecal incontinence have higher quality of life than those with it. Does a 1-week clean interval affect quality of life? Again, an interval we sometimes talk about. Guess what? No. What kind of fecal incontinence affects quality of life? Any. So in a spark of literary brilliance, I wrote this in the paper. Simply stated, any unexpected passage of feces may negatively affect one's quality of life. It's kind of simple, but that's what people experience. What about protective undergarments? Regardless of whether or not you have incontinence, is your quality of life lower if you wear undergarments? Yes. Does it matter how many? It doesn't. And this is also true if you're dry. You're wearing them just for protection. It affects your quality of life negatively. So what matters? Incontinence. The effects of urinary and fecal incontinence are also additive, and wearing undergarments is also affecting your quality of life. But again, these are averages and differences between people within a population. What we don't know yet is over time, does treating incontinence improve quality of life for that individual? And over time, which treatments might be better than others for an individual? And so the next point is, when you get real busy, when you have a lot of data, remember why you started. And I thought back to why I started going into this. It was really about the kids. I just talked about a lot of the adult data. So what about incontinence in kids with spina bifida? We have a lot of resources devoted to treating incontinence in spina bifida among children. And I mentioned this, the study here from UBC that showed that there's really no improvement in quality of life after treating incontinence in kids. That's the only prospective study out there. There are also cross-sectional studies that have conflicting results, so we really don't know. But does incontinence matter to kids at all? We know that kids are better after surgery, but there's real no data. So are we treating ourselves or are we treating parents? And so this level of data is totally anecdotal. This is level D. And we also know that some kids don't care. They're fine being wet. Does the impact of quality of life develop with time? And that's just a clinical observation that some people develop an interest in getting treatment. Again, anecdotal. So the goal here was to determine if the impact of incontinence, both fecal and urinary, on quality of life in kids and adolescents with spina bifida. And so 286 kids were enrolled, and looking here, 44% had both urinary and fecal incontinence, and only 18% had neither. The number is very similar to what we saw with the adults. So in other words, most people had incontinence. Any urinary incontinence was associated with lower quality of life among 10 to 17-year-olds, but not among 8 to 9-year-olds. So the younger kids, the youngest in the study, were not bothered. Any fecal incontinence was associated with lower quality of life for any age. Does a urinary incontinence dry interval affect quality of life? No. Does the amount of urinary incontinence affect quality of life? Not among the 8 to 9-year-olds. They weren't bothered at all. 10 to 13-year-olds, yes, but more so among 14 to 17-year-olds. And this approaches the findings among adults. What about the fecal incontinence clean interval? It doesn't matter, the 1-week interval. Does the amount of fecal incontinence affect quality of life in kids? No. No, any amount of fecal incontinence affects quality of life. And so urinary and fecal incontinence are both common and usually coexist in this population, and they're independently associated with lower quality of life. And urinary incontinence is negatively associated with quality of life in an age-dependent fashion, starting at about age 10 and increasing to 14 where you reach adult levels of impact. And fecal incontinence correlates with lower quality of life regardless of the age. And so this is very similar to what we saw in adults. Quality of life is lower with higher amounts of urinary incontinence, and fecal incontinence has a more uniform impact, regardless of frequency or amount. And so there's this concept of social continence based on people without spina bifida. You void 6-7 times a day, you divide 24 hours by that, you get 4 hours. That's social continence. You can be dry for 4 hours. But that definition, based on a time interval, has really no quality of life relevance to kids, teens, or adults with spina bifida. And so there's no evidence to support the notion. So let's go back to clinical relevance. How can this help? What difference in quality of life scores is important? Think PSA. Is a difference between 2 and 2.1 significant? What about 2 and 3? And I'm not talking about the population, because you have millions of people, those numbers will be significant to some degree. But what about the patient you're seeing in clinic? And so is a number without a clinical meaning clinically useful? And I would say no. And so this brings up the concept of a minimally important difference, or MID, that can be appreciated by individuals, where 2 scores, when a patient reports them, are able to be appreciated by the person filling it out saying, yes, these are different. And most quality of life instruments, unfortunately, don't have them published. What's the difference that will be important to you? I don't know. For Qualis, we did derive them. And so to illustrate that point, we did a study where we looked at pairs of caregivers and patients and looked at how they would underestimate or overestimate the quality of life of people under their care. We're not sure if that even happens. And then also we wanted to know, are some caregivers just better at estimating the quality of life? Maybe you live with someone, maybe you're a mom, maybe you're more attuned to things. And so we enrolled 329 of these dyads, patients and caregivers, anyone over 8 for the patients was enrolled. We administered Qualis, and looking at the correlation, here's just the bladder and bowel domain. The kappa score, which shows the agreement, which is a test for the agreement between scores, was 0.15. You don't have to be a statistician to know that's pretty low if the range is 0 to 1. That's not a very impressive score. And the category is slight. It's not a very good agreement there. So what about a bar graph looking at the differences between scores? This is for the kids, bladder and bowel domain. Zeros down the middle. Those scores agreed. The median difference was 0, so on average, it was pretty good agreement. But you can also see that there are differences. There's a bell-shaped curve around the 0. But are some people just outliers that could be clinically important? And so the MID for this bladder and bowel domain for kids was 10. If you draw lines there, plus minus 10 from 0, anyone on the left the parents underestimated quality of life, on the right overestimated it. Only 51% of the parents were within the range. Teenagers, it was similar to the adults. And so overall, for all ages, parents were within the kind of the clinically relevant range only 58% of the time. 42% of the time, they would either underestimate or overestimate to a clinically significant degree that can guide your decisions as a clinician. And they were just as likely to over or underestimate it. This was true for all the other domains we tested. Unfortunately, we also found out that no one was better at predicting quality of life than others. All the caregivers were equally incorrect. So almost half of the time, caregivers misreport quality of life of patients under their care to a degree that's clinically significant. There's really no surrogate for self-reported quality of life. So whenever possible, ask the patient. The future of where I think this is going. Measuring quality of life gives kids, teens, and adults and their families a voice to participate in their care. And it's really what they care about. And this presents some novel challenges and questions. And to step back a little, I just spent the last 20, 30 minutes talking about that incontinence matters to people with spina bifida, and you can say, well, yeah, you knew that from the get-go. I've just shown you a better way of measuring urinary and fecal incontinence. You kind of shrug your shoulders, that's fine. And we can measure quality of life now, and that's fine too. And those are not groundbreaking ideas in the grand context of things, but they're building blocks to where this is going. So I want to go back to the 1960s. In the 1960s, there was an awareness of an epidemic of MIs and strokes becoming an increasing problem. Cross-sectional studies at the time were showing that there was an association between high blood pressure and cholesterol and your risk of developing an MI or a stroke. But the question came up, does lowering blood pressure, does lowering cholesterol actually decrease the risk? There was a little message, there we go, box that popped up. There we go, we're good. Okay, thank you. And so if lowering blood pressure or cholesterol decreases your risk of developing cardiovascular disease, what are the cutoffs? When do you treat? When do you not treat? What is the trade-off and the benefit between the risk of treatment and actually delivering care? In other words, you need prospective studies to determine that. And in 2020, it's a no-brainer that you should measure cholesterol and blood pressure. It's just part of clinical care, part of life. But in the 1960s, no one knew that. And so in 2020, there's really no well-designed prospective studies that would measure quality of life and incontinence treatments in spina bifida. And we know that we can make people dry to a degree, but doesn't make them better. We still are at the level of grade D evidence. So which treatments improve quality of life now that we have a tool to measure it? And how can patients become more engaged in their treatment decisions to maximize their quality of life? So I'm in my first year of funding of a 5-year grant from the NIH to look at those questions in a prospective study, which is very exciting. How do we build a healthcare system to ensure appropriate care and independence? We're validating QALAs in different languages. We've just completed our Japanese validation, and we're doing that in several countries in Europe as well. Also, QALAs has been selected as the quality of life instrument to be incorporated in the National Spina Bifida Patient Registry run by the CDC, which is very exciting because now people have access to it and it can also be used clinically. And so here I wanted to acknowledge my collaborators, everyone who's helped with my studies, and the hundreds of patients and families who helped us do this research. Thank you.